The Cuyahoga County Committee of the Whole for Thursday, November 14, 2013 will please come to order. The clerk will please call the roll.
Calling the roll, Mr. Miller.
Here.
Mr. Brady.
Here.
Mr. Germana.
Here.
Mr. Gallagher.
Here.
Mr. Schron.
Here.
Ms. Conwell.
Here.
Mr. Jones. Mr. Jones is absent at the moment. Mr. Rogers. Mr. Rogers is absent at the moment. Ms. Simon. Ms. Simon is absent at the moment. Mr. Greenspan.
Here.
And Ms. Conley. There is a quorum.
Thank you very much. Do we have anybody who has signed in for public comment related to the agenda?
Yes, we do, Mr. Chairman. The first speaker is Tim Walters. If you'd come up to the microphone, state your name for the record, and you'll have 3 minutes to speak.
Good morning, Tim. Welcome to the committee. You have 3 minutes.
Good morning. My name is Tim Walters, and I'm Executive Director of the Metanoia Project. We operate a seasonal shelter and hospitality center on the near west side for a segment of our homeless men and women. For the past 2 years, we have received $25,000 a year in the county budget, money that is critical to our ability to maintain our program. We have not been included in the coming budget, and I'm here to ask we be included. Our primary target population is what we term the shelter-resistant homeless. Men and women who, for a variety of reasons, will not use our regular shelter system. Their resistance may come from fear based on a previous bad experience, an inability to function in closed, crowded environments because of a variety of mental illnesses, or a resistance to a structured setting. Instead, then, they live on our streets, at improvised campsites, or in abandoned buildings, places of great risk, especially during our winters, posing a variety of challenges to our safety forces. We will open this year on November 15th and remain open on weekend nights from 7 p.m. to 7 a.m. until April 13th. We occupy the first 2 floors of St. Malachi Parish Hall at West 25th and Washington on the near west side. Both men and women use our facility. Each evening open, we provide our guests a meal, access to a variety of resources and programs, and most importantly, a safe, secure place to spend the night. Among our resources are access to doctors, nurses, and mental health workers, clothing, showers, support groups, and job development classes. Last winter, we averaged about 100 guests for our evening meal, with 50-some staying overnight. We were open a total of 87 days from mid-November to mid-April. We also opened on all holidays during our season and during the week when the weather became extreme. Holidays and extreme weather days are part of this year's plan as well. We do not portray ourselves as better than our regular shelters, just different. We respect and acknowledge the need and value of those shelters, but are also aware that there are some who they will not reach and as a result cannot help. Our small size and focus enables us to reach these men and women. We employ a staff of 12, many who are formerly homeless and in various stages of recovery. We supplement their natural understanding of the needs of our guests with training specifically designed to assist them in recognizing and responding to needs and concerns. Perhaps most importantly, we should respond to each individual with dignity and respect, responding to them as individuals who have been placed in a perilous and vulnerable situation and whose ability to respond has been compromised by a variety of circumstances. Our focus is to first bring our guests into a place of safety where we can then begin to help them address and respond to the many issues that prevent them from moving from their present conditions. Thank you, and if there are any questions, I'd be glad to answer them.
Thank you very much. We appreciate the special role that you provide in serving the homeless, and I'm pleased to report that we've now determined that, while not specifically referenced, there is funding in the current budget as proposed to continue at $25,000 per year for the Metanoia project. And I'm going to recommend to my colleagues that we add a little bit of language that reaffirms the council's support for the program.
Thank you very much. Appreciate it from all of you.
Okay, thank you.
Lynn Wieland, I apologize.
Good morning.
Good morning. Welcome to the committee.
Thank you. I'm here today to ask that you not forget your elderly constituents when you prepare the next county budget. As I'm sure you know, each and every one of you have elderly in your communities that are suffering and struggling. The providers of senior services have taken a huge cut, as I'm sure many other populations have, except that seniors don't tend to be the in population these days. The Cleveland Foundation used to be the third largest funder of senior projects, but now education and economic development are their priorities. The same has happened with United Way. The federal funding for elderly programs comes from the Older Americans Act, and it has not had any increases in over a decade. At the state, the one line item that funds senior services, basic services such as transportation, congregate meals, delivered meals, etc., has been cut in half over the last 10 years. Most centers are now receiving 1/3 of the funding from the state and federal government that they received in the last 10 years. And let me not forget our own division of senior and adult services. Their budget is a little over $6 million, which is half of what they received just a few years ago. But this trend at the state and federal government is affecting everyone in Ohio. However, the local funding is quite different. Many believe that there is not more advocacy efforts for more state funding because there are 69 senior levies in Ohio, and they pass 90% of the time. However, in Cuyahoga County, we have taken a different approach. We have decided that we want all of our health and human service levies to be combined. The senior levies in other counties go for the congregate meals, the transportation, the delivered meals, and other essential services. In Columbus last year, they passed a substantial increase in their senior service levy, and they are now providing $34 million for services in their community, and they have 100,000 less seniors than we have. And their senior levy goes for many of the services I just mentioned. And that does not include their adult protective services. They actually receive $1.5 million in addition for their adult protective services. It does include, though, their option program, just like our option program that we have. It's not identical, but it's similar. However, we have 200 people waiting for our adoptions program in Cuyahoga County. The programs that I mentioned, including our options program, helps to delay more expensive programs like Medicaid programs, the passport program, assisted living, and nursing home placement. This saves you and me and all the other taxpayers in Cuyahoga County a great deal of money. Matter of fact, the most effective programs that are available are from senior centers, and they are the first line of defense. They provide these essential programs in the community, yet they are the first to be cut and the last to be funded. They connect the elderly to the services they need very, very quickly, and they are our eyes and ears in the community to let us know when they need more significant services. I am in conversation with them daily, and some of them are calling me right now concerned that they'll either have to cut services or actually close. Many of these are in the Cleveland area, but your municipalities are suffering too. They took huge cuts when, not this budget, but the one before. Lakewood, Euclid, Parma, our three highest elderly populations, except for Cleveland, took $4 and $5 million cuts at the last state budget. Not this one, but the one before. So please don't forget your elderly constituents. With $107 million new dollars from the levy, I'm sure there will be sufficient funds to care for all of our vulnerable populations. I'd be happy to answer any questions you might have.
Thank you very much for your testimony.
Thank you for
We'll
your
be
time.
hearing senior and adult services today during the hearing. Are there any further?
No, there is not, Mr.
Okay, thank you very much. We'll move on to consideration of the budget resolution. Would you please read the item into the record?
Resolution number 2013-0229, a resolution adopting the 2014-2015 biennial operating budget and capital improvements program and declaring the necessity that this resolution become immediately effective.
Thank you very much. And first on our agenda today is the Alcohol, Drug Addiction, Mental Health Services Board of Cuyahoga County. And presenting is the Director, Mr. Bill Danahan. Welcome to the committee.
Good morning, Councilman and Council members of the Committee of the Whole. Thank you for allowing me to come here this morning to present our budget. Currently, the Adams Board receives $30.8 million from county service levies to services for individuals that are receiving Medicaid that is not covered by Medicaid. That includes housing, vocational employment, peer support, prevention, education, information, detoxification, and crisis stabilization, and treatment that is not covered by Medicaid. Those are some of the things that we are asking in our budget, plus others that are not mentioned that I will go for in a little further detail. We are grateful for this funding. However, it is noteworthy that Cuyahoga County has the lowest per capita levy spending on mental health and alcohol and other drug addiction services as compared to our peer counties are just $27.23, and that is noteworthy in the documents that we have here for you. A needs assessment was completed in April of 2011 by the Center for Community Solutions of residents below 200% of the poverty level. It showed that the board was serving 57% of the people with mental illness and 32% of the people with alcohol and other drugs. It is estimated that 27,512 individuals with moderate to severe disorders and 19,775 individuals aged 12 and over with substance abuse or dependency disorders in Cuyahoga counties go unserved at that time. We estimated at the board at that time we needed over $45 million in extra funding to serve those not being served. Our request today is for $16,185,000 in new funding in addition to the $34.8 million that we see for the budget to continue and expand prioritizing non-Medicaid programs that serve adults, adolescents, and children. And very realistic. We know that $16 million is a lot of money. That, ladies and gentlemen, is our need, and we understand the financial pressures the council is under. I would be remiss, however, not presenting to you the need that people are requesting. This is developed in collaboration with our providers and hundreds of partners and stakeholders that we have met with over the past several months. So I'd like to draw your attention to the various programs, and in essence of time, I won't go over everyone, but I'll be more than glad to answer questions. The first on the adult, let me point out that we broke this up by adults and children. The first grouping is adults. Detoxification, Suboxone voucher program, and methadone clinic. In visiting individuals that are going through addiction, we're finding that the Suboxone program does work. I specifically met addicted individuals at Rosary Hall over the last couple weeks who told me clearly that they have relapsed 2 or 3 times until they got on the Suboxone program, which works, and they had been clean for the last 2 years. That is significant. In our methadone clinic, the budget was reduced over the last 3 years by nearly a third, yet their need is increased by nearly a third. Those are individuals that are waiting to get into and provide services for the methadone clinic. You see the numbers being served now and those that we would increase in the serves and the dollars asked for these individuals. I won't go over every one of these individually, but I will make comments on those that I think that are worthy of comment other than what we have in our document. Criminal justice, residential subsidies. This county has the most individuals coming and going in the criminal justice system. As noted in the Plain Dealer about 3 weeks ago, we've been doing a pretty good job over the last 10 years. We could do a better job, and that better job is when people return from prison, they need to be away from where they were and have housing. This is residential subsidy would achieve that to reduce the recidivism for the individuals coming back from prison. which is a safety program as well as a program to remove them, to provide subsidies for their treatment services. Our crisis intervention team, this is the program that we train police officers. We've trained about 680 police officers in the county. This does make a difference. We could train more, and this is an expansion of that program. And prevention is one of the hardest hits over the last number of years. We're asking for prevention, training for emergency primary care physicians to learn how to detect medication. We're finding out that physicians in ERs and other areas do not have the ability to detect and many times overprescribe medications that lead to addiction. I'm not putting the blame on them, but that's the report that we have out. The opiate and heroin epidemic is alive and unbelievably too well in our county. And it's not just treatment, it is prevention. And until we really get serious about prevention, I believe it's going to continue. So we have asked for funding in that area for adults. In terms of our crisis and clinical services, we're asking that we deal with the reduction and loss of psychiatrists in our system, for part-time psychiatrists, to deal with those that need services. Unfortunately, when there are a long waiting list, and this also has to do with the lack of number of psychiatrists in this system. Expansion of crisis team for alcohol and drug services. We do not have a crisis intervention team for alcohol and drug services. That is part of our mission. We have it for mental health, and we do a pretty good job, but we need it also for alcohol and drug addiction. In terms of special populations, older adults is significant in terms of their special needs. Among them is the adult guardianship program, which continues to grow and needs funding. Consumers need transportation to go to meetings, to go to treatment, and without transportation, they would not be keeping up with their treatment. We have cognitive enrichment therapy, which makes a difference with individuals that have severe mental illness in terms of training. In terms of special populations, again, we opened up the Seasons of Hope, which deal with women who need a safe place on the east side. We would like to have the same thing on the west side of Cleveland. In terms of housing and recovery services, we have several special populations that without subsidized housing, they will continue to recycle in and out of the system. In terms of our adult care facilities and our halfway houses, we're finding that ERs are calling us saying emphatically, you need to increase the halfway houses in Cleveland, whether they're medically assisted programs or the 12-step total sobriety program. In terms of one system that is a problem in our system is that Medicaid does not cover everything. For example, a social worker going to a home that transportation does not cover. And they are disincentives. They're not billable for an agency. And we want to make sure that while people are on Medicaid, that they have social workers with the ability to go to a home or go to a jail or go to a hospital and provide the services. And this would be the unbillable services that we're talking about. Training and special populations, as noted, has reaped significant benefits, so we're asking for services in the training area. And turning over to children, the opiate epidemic, while in the previous it was noteworthy in the 16, 17, 18-year-old age group, is now going down to the 12, 13 and 14-year-old age group, and we need to have a very specific prevention program in the schools. In terms of restoration of programs that we had over the last number of years that have been reduced due to lack of funding, we need to restore those programs. We do have a school-based mental health program in some of the school districts, one notably in Cleveland and going to Garfield Heights and Maple Heights, but there are other school districts that could reap the benefit of our mental health intervention, education program for mental health and addiction services in their schools. Here's some of the schools noteworthy would like to have that expanded to those schools that would benefit from these. We need a serious 4-bed detoxification program for children. We have nothing going there right now. Our crisis services team, we'd like to have a mobile crisis service teams for children that would expand to what we're using right now. We would like to be with the times and have a crisis chit-chat text that we've just started that we'd like to see expanded that has tremendous benefits. And our behavioral health criminal justice program, which we found was extremely successful, we'd like to double that and continue it. Those are some of the things that we'd like to ask for, we are asking for in our budget, and I appreciate you listening to me, and I'd be more than glad to answer any questions that anybody has relative to my presentation. Thank you.
Thank you very much. I would note the presence of Councilwoman Sunny Simon to our meeting, and to start our questioning, we're going to start to my left with Ms. Simon, if you have any at this time. Okay, Ms. Conwell.
Yes, thank you. Through the chair to the director, what impact with the services has the decrease of staffing from 2011, which were 69, to 2013, which was 48? What impact has this had?
Mr. Chairman, to Councilman Conwell, which were you referring to?
In our budget book, there's a staffing pattern for your staff. You had 69 staff, and then it drops down to 48.
Okay, that was a result of a number of things. The most predominant one was the consolidation of the Alcohol, Drug Addiction and Mental Health Board and the Mental Health Board. So that was a result of individuals doing two jobs as opposed to one job, especially on the administrative side. So we didn't need two directors. We didn't need two health and human services persons on the administrative side. So we reduced the staff, and those dollars were used to be saved for services for our citizens.
Thank you. Can you provide a breakdown of the type of miscellaneous funding you receive revenue from? And you can provide that later. In our budget book, it states the miscellaneous funding that you receive, and I know that's probably with fundraisers and things of that nature. Could you provide council with
Yes, we will.
With the breakdown for that? And what cuts do you expect with the state and federal for 2014, 2015?
The feds have reduced funding from SAMHSA through the sequester and a number of other areas. And it is really significant here in our county. It represents in one area, especially in the alcohol and drug area, about $1.8 million. While we received more funding from the state, it's offset by some of these cuts, and I'll provide that in detail for you.
Okay, thank you. And I have several questions, but I'll ask one more, and then I'll let some of my colleagues until it comes back to me. Mr. Director Dennehan, taxpayers want to know how the dollars that Adams Board spends is benefiting them. Could you share with us today?
how the dollar
If a
spent for the
taxpayer
unemployed.
asks me how the money that we're providing to them, they want to
Well-
know how it's benefiting them.
Well, when a person has an episode in terms of addiction, they would appear at a emergency room, and if it is so severe, they could be sent to one of our detoxification centers, and then from there to a off-site treatment. And if they have a mental health issue, they could go to one of the emergency rooms and receive treatment and either be assumed in that hospital or sent out for outpatient treatment. The challenge that we have today is that for those that are moderately ill, that could be on a course towards serious illness, have an extraordinarily long waiting list to get served. And to that citizen, I point out that we're not serving all the citizens at this point in time. And we do, I believe, a better job on the deep end where people need the crisis services in a state hospital or emergency room. But for those services that provide them through a path of recovery, unfortunately, ladies and gentlemen, we do not do that good of a job. And hopefully what I've mentioned to you in this budget will address some of those things.
Councilman Tron.
Thank you, Mr. Chairman. If I understood my colleague's question as far as the headcount, the reduction in headcount was for consolidation of administrative positions, so it was not for performance of delivery individuals. That was the way I understood the response. Is that a correct understanding?
Mr. Chairman, to Councilman Schwan, are you asking that it was a direct response for people to perform their jobs?
Yeah, Ms. Conwell indicated what the change was in personnel, and your response, I believe, as I understood it, was a consolidation of some of the administrative positions because of not of a need to have duplication of some of those senior positions.
That's correct, sir.
And so I just want to make sure I'm understanding that was not a reduction in those numbers to response to my colleague of delivery personnel versus consolidation of administrative personnel.
That is correct, sir.
Okay, I just want to make, so that when somebody comes back outside of this hearing and says, wait a minute, there was a reduction in headcount, we want to reinstate that, you're not advocating reinstating those administrative positions?
No, I'm not at this point in time.
Okay, I just want to make sure I'm clear as far as that. Your request here today is for a 50% increase over what was in your initial response on that, if I'm understanding the $16 million. Is that correct?
My request is for $16.1 million.
Which is basically a 50% increase.
Pardon?
About a 50% increase?
Yes, sir.
Yeah, a little. And if, as you know, in the budgeting process, everything does not always come forward as the request versus the response, have you prioritized what that 50% would represent? You went through a list of items without necessarily prioritizing those in your presentation. Do you have a prioritization in that list of requests?
We would go through and make a prioritization. The prioritization would deal with further treatment, prevention, dealing with residential care, special populations such as the older population, our transitional youth. So those would be some of our priorities. We've already established our priorities, and we go back to those priorities that we established and have them fit into whatever council deems appropriate that we'd receive.
Yeah, but could you do that before we get to that point, so that we can have that match up with your request, so we could have some kind of understanding as to where your priorities are? Perhaps some of those might align with somebody else's, and if there's a gap by one of the other service providers, perhaps we might find there's some overlap or some intertwining between
We will do that,
requests.
sir.
Thank you.
Director, I have one question. In some of the visits that I had at mental health agencies served by your board earlier this year, they said that they had very good programs to identify families where there was risk for either child abuse or domestic violence, and to provide some services to help prevent such things. But they said that generally they were so busy responding to crises that they did not have a lot of opportunity to do the prevention work. And my question is if we provided additional money, could more prevention work be done, and would that be high on your priority list?
Mr. Chairman, yes, prevention would be high for a couple of reasons. One is that, as somebody explained to me some time ago, and the comment was that without prevention, your cost for treatment doubles or triples. So we need prevention to deal with a continuum of care to help reduce the very thing you're talking about. So yes, we would rank prevention up there, and it's one of those areas that over the years that we depleted putting the money in the treatment area. It is essential that we have prevention, and I would consider it one of our priorities.
Councilman Gallagher.
Mr. Denahan, how many, if you know, and you probably don't know this right now, but I appreciate it, how many programs underneath the Adams Board have been federal or state programs that were funded, that are now not funded, that the county now funds to maintain?
Okay, we could provide that for you.
It would, off the ballpark?
It's kind of difficult to give you the ballpark. There are some that, and I can't remember exactly, that are no longer funded, and there are some that have been reduced a good amount of money, and I will provide that for you.
Well, that leads to my next question, that it seems that the majority, if not, probably the majority of your target audience are the target audience of Obamacare.
I'm sorry, sir.
The audience that you're targeting here, that your clients are basically that level of people that the Obamacare situation was positioned for. And if they don't qualify for insurances within the Obamacare, they're now being shifted over to Medicaid. Doesn't that lessen the burden on your organization?
Well, all these services are services that Medicaid, or as you point out, Obamacare doesn't pay for. These are services that are beyond Medicaid, that enhance people through recovery. In Ohio, Medicaid can cover 25 different services, but Medicaid in Ohio only accounts for and pays for 7 of those services. The services that I have presented to you are services that will not be covered by Medicaid and are not covered by Medicaid, but they are essential to recovery. So we will have more people in that area, as you point out, that will be seeking more services that are not covered by Medicaid. So
nobody that's a target of yours for help receives any Medicaid at all, any benefit in help?
Mr. Chairman, to Councilman Gallagher, we know that more people are going to go on Medicaid for some basic services. The services I have in front of you are not covered by Medicaid. None of these services. And we're asking for consideration for these services to ensure that they continue through their recovery and that they are essential to their recovery.
And are not and will not be covered by Medicaid, or we don't know?
No, I know that everything that I
Will
have in
not?
front of you is not covered by Medicaid.
Right now, but will it?
No, they
Because-
won't, sir.
At all?
No.
Because I mean, the bill's like that thick, so I don't.
I wish they were, but they're
Now,
not.
I read somewhere, and I talked to someone, some state rep somewhere, that the state of Ohio this year, this session of at least the House, I believe,
Mm-hmm.
is going to be doing something on recovery. Do you know what I'm talking about?
Well, I don't know if this is relative to that. There's a number of things going on in the House. One of them is not only to repeal what the governor is doing on the expansion, but I think there is a number of programs to have greater accountability in terms of those on Medicaid and going through the Medicaid process.
You know what, I'll get that for you. It was a state rep, and they're going to push something through
Okay,
to alleviate the recovery services. It's not in bill form yet, but I think
I'd
it's my state
appreciate
rep.
looking at it, Mr. Chairman.
I'll find that out, and I'll move that on to you. Thank you.
Okay, thank you.
Councilman Germano.
Thank you, Mr. Chairman. Ironically, I was going to be asking the question about the Affordable Care Act as well. I guess can you give us kind of an idea of how much of the population is children and how much is seniors of the total?
How much of, Mr. Chairman, Councilman Jermaine, how much of the population is not being served?
No, that you serve, or that is your target. I'm just wondering, how many, is seniors a big part of this? Children a big part of this, or is it the remaining?
Mr. Chairman, Councilman Jermaine, I'm not sure if I understand your question.
Well, what I'm trying to get at is being a senior, and we heard already testimony this morning about the aging of this county. I'm just wondering if how much percentage is senior service and children service in comparison to the total need?
Well, I think if I understand your question, how many of the services are children, how many are adults? It's usually 1/3, 2/3. Children do advance in age and grow up to be adults, but generally it's about 1/3 of the funding is children, if that's what you're asking, and about 2/3 of the funding is for adults.
Okay, of that 2/3, how much is seniors? How much is
Of that 2/3,
What I'm trying to get at is
A very
I'm
small
trying to-
amount, Mr. Chairman.
Okay.
Very small amount. In terms of directed towards seniors, it's not a large sum of money, and that's one of the reasons that we put it in there. Not only for prevention, but dealing with such issues such as hoarding, the issues of dementia, those that have Great Depression for a lot of reasons. These are very serious issues, and our population is expanding, and one of the areas that is expanding, and with it is a need for guardianship for individuals that can't take care of themselves and need somebody to ensure that they are taken care of appropriately by whatever system they're in. So it is expanding, Mr. Chairman, but I don't see the services expanding with it, and that is one of the reasons it would be a priority.
Okay, thank you.
Councilman Brady.
Thank you, Mr. Chairman. Listening to my colleagues, I think that one of the themes that I think kind of runs through some of the questions that are being asked is we know that a very important part of the county's responsibility, some would say the most important part of the county's responsibility, but at least it's close, is what we do with our health and human service budget. And we're trying to, I can understand, and I do the same thing, try to understand how to untangle what not only you do, but what others do, and how much overlap there is, and how needs are distributed, and how some needs are not met, and some needs are met, and what we can do about it, if we can do anything about it. So that we talk about what does the Affordable Health Care Act mean, so that we talk about what does Medicaid expansion mean to you, and what does it mean to Metro Hospital, and what does it mean to everyone else in our community. So we talk about the Medicaid waiver expansion and the sales tax that is generated from that and how that might be used. So we talk about what we're able to do with seniors while you at the same time talk about what you're doing with seniors. And so, or we talk about what legislation may be introduced or not introduced at any given time in the legislature, which I know you're quite familiar, maybe not with every piece of legislation, but with the process in the legislature, and do as good a job as any as keeping up with what's happening in the state capitol. So I think that what I'm looking for, and this is obviously not a question, I'll get around to that if the chair will bear with me, is that trying to untangle how these services are delivered in Cuyahoga County so that we can most efficiently and effectively reach all of these populations that we're trying to reach without overlap. And so, some might think, given the things that you speak to, that you are attempting to do everything. That's obviously not the case, but it could sound that way because we hear from other people that they do things that sound, at least, to be similar, and we wonder what the connections are between the Adams Board and these other services. You are located, at least in terms of your headquarters, on West 25th Street. You go down the street, a 10-minute drive, if that, with the lights, and you're at Metro, where they take in people who have who are uninsured, but also take in, obviously, people who have health and have addiction problems, people that have mental illness, who are out on the streets and end up somehow in need or hurt and end up at Metro, that are not part of they're not part of your system. You're not a mile apart, but you're serving a lot of the same people. And so trying to untangle that is part of the problem of trying to figure out how to fund it. And so this is one of the things that I'm working hard, and I hope that you and others will help us try to understand, how we can work better together, and why it is that some of these things don't seem to us to interface. We have problems with hunger. We know in the senior centers, part of their mission is also the issue of seniors on fixed incomes who literally go there to eat, and so as we go through these issues, they are interconnected, and we have resources, but obviously we all know we have a limited amount of resources. So all people being well intended on this panel, we're trying to determine how best to distribute the resources we have. Not an easy thing to do, and maybe no perfect way to do it. Now, that said, specifically, I'd like to have you speak a little bit more toward the heroin problem that has surfaced over the last year and a half, couple of years. We've heard from our medical examiner, so there's a crossover there. But I know personally had the unfortunate, and some other folks actually that I know, had the unfortunate experience of knowing a young man who died of a heroin overdose last year that I had known years ago, and he was, in his 40s, and so this is not abstract to me. Mm-hmm. And I was wondering what more you could say about the heroin addiction or heroin abuse problem that we have. And as someone who's been around a while, I've seen these things as you have and others come and go. Maybe not entirely ever go, but spike. Whether it was the crack cocaine in the 80s or what it might, or the abuse of Oxycontin, or now the apparently wide availability of some kind of a cheap heroin. I say this only to try to highlight at least one area where these problems are always present and are very real, and and kill people.
Thank you, Mr. Chairman, to Councilman Brady. I've been going to halfway houses and treatment centers for the last 2 months and meeting with groups of addicts that are in recovery. And I ask them 3 questions. How did you get here? How are you straight today? And what do you think we should do to change the system? And how they get there, it generally breaks down to 2 areas. They started smoking marijuana at a very young age, and they progressed up into their teens, where they eventually got into heroin. The other group is at any age, they have an accident and they're in the hospital. They're a football player and they have a knee injury in high school, and they're in the hospital. And as they're leaving, they're given a huge dose of an opiate. And they use it, and they want to continue the buzz, the glow. And they're told by their friends on the street, in school, you could buy a hit for $10 of heroin. That's real in our county right now. A 35-year-old mechanic breaks his wrist. He goes in for treatment. Same thing happens. He talks to his friends, and as recreational use, they could get heroin easy on the street. So there's another part where there's an extraordinary overprescription of opiates in our state. That's already been documented. And that leads to those individuals that want the glow, get into addiction. That's the other half. So getting straight is a number of things. If I'm at a place where we pay, where it's medical assisted treatment, such as Suboxone and so forth, then they say they need to continue on that Suboxone, or they need to continue on that treatment, and along with a 12-step program. Those that are not in medically assisted treatment, which are just as successful halfway houses, adopt the total sobriety and 12-step program. The changes to the system that they recommend that is in part of this is an increase in detox because of the waiting list on detox, and an increase in halfway houses, whether they're medically assisted treatment or otherwise. So here's what we know for sure, and you sort of alluded to it in your question. If you could imagine a line of accidental deaths, and in that imaginary line right here is crack, cocaine, meth, and so forth, and we see the crack and cocaine wars in the 70s and 80s, and it's an imaginary line here along with heroin. These are accidental deaths. The next line would be homicides. Now, actually, next line is accidental falls, people falling off a ladder. The next line is, then the next line is homicides. Next line is suicides. And the next line is motor vehicle accidents. Right now, today, heroin is above everything, and that's what the medical examiner testified to. Heroin is up here. Went from all the way, jumping up and down, the spikes, as you said, then all of a sudden it went up here. There's a whole lot of reasons for that. I'm not dealing with the reasons, I'm dealing with the reality of what works. What works is detoxification, is the halfway houses, and longer treatment. And that's embedded in this proposal. So on the 21st of November, the U.S. Attorney and Cleveland Clinic will be having a heroin summit at the Intercontinental Hotel, which is free to anybody, from 9 to, I think, 3:30, that will be talking about what I just mentioned to you. And there's a number of sessions with the hope that out of that conference will be recommendations looking at how it began and how we deal with in terms of prevention, in terms of training of doctors, and in terms of limiting the prescription of drugs to patients, to getting into middle schools, high schools, and talking with community members. I had the pleasure of being with Councilman Greenspan yesterday, in which we met with West Shore mayors, talking about this and many other issues. And it's having that public discussion where people say, okay, what are you going to do about it and how can we help? One of the things that's happening, I was on a radio station about a month ago, and it was really clear to me that mothers of sons and daughters that they've lost to crack cocaine are saying, wait a minute, I don't know how it happened, and it happened in my family, and I want you to do something about it. You cannot allow this to continue. The system that we have today it needs to change in terms of how we talk about prevention. We have to get into the schools. I was at Bay High School 2 months ago, and a national professional.
Mr. Director, the importance of this issue it's just the most important. But we spent an hour, and Councilman Greenspan hasn't even asked a single question yet, and we're on track for a very, very long day. Questions and answers need to be more crisp and more budget focused. We have a Health and Human Services Committee. We need to be pointed, or else we'll never get done. Please proceed.
Yes, sir.
Yes, I agree. That'll be fine. I think it is important sometimes, although it's difficult to do, I need to be able to respond to what I'm hearing from my colleagues. I think maybe others do too. And our ability to have a discussion, since we're not allowed to have any discussions outside of this room, it's necessary for us to be able to talk to each other along with hearing from the folks that come in front of us. But I appreciate your guidance and understand how difficult it is to try to corral this thing.
Yeah, but it needs to be a little bit, yeah. Ms. Conley.
Thank you, Mr. Chairman. I don't have specific questions. I just appreciate the concern, and I've been involved with this heroin addiction problem for many, many years. But I think that one of the things we need to point out is the collateral consequences of this addiction, because that person who overdoses has a family, has children, and all of these services are needed that actually flow from the other problems. If you have a mental health issue, then you still have a family that needs counseling or needs care, or doesn't have has lost their sole source of income because of the mental illness. I mean, I see so many people with mental illness problems that that we don't have anything to do, place to send them. So I just like to, not so much as a question, but, and the other thing I would say, that it's a senior citizen. A senior citizen doesn't become needy overnight. They were a needy teenager and adult, and then they became a senior citizen. So, I'm so concerned about the prevention, but I know that you've asked for a big chunk, and I know some of my colleagues are not so generous in terms of giving you the whole amount of money. But we will have to work on prioritizing some of these requests, and I think you can work that out with the committee.
Thank you.
Councilman Greenspan.
Great, thank you. Council President Connolly actually hit it somewhat on the head in the sense that, we all know the financial situation of this specific levy fund, and that we saw significant reductions in the revenue as a result of the property valuations. The voters voted to restore the funding back to just about the level in which we started when we took office in 2011. Which gives us an excellent opportunity, as Council President Connolly said, to start to prioritize the core values of the delivery of the type of services, not only health and human services, but general fund expenditures as well. And there have been, and we know, significant reductions in the health and human service appropriations that were prepared in this budget, because the budget was prepared with the expectation that the levy, with the revenue as it was projected without the levy. Now the levy passed, there's additional funds available, and that's where we need to identify the priorities. Question I have, though, in looking at the budget, outside of a $500,000 reduction, your budget as presented to us through the administration is the same, correct? You didn't see any of the significant cuts that some of the other areas in health and human services realized. Is that correct?
I'm not sure. Our initial budget we submitted of the $34 million is the same as last year. Yes, sir.
Okay. All right. Great. All right. So there's been no increase, but there's been no. I noticed there's a $500,000 reduction. There's been no meaningful reduction.
I think that was as a result of the funding this council gave for one-time funding for Bridgeway.
Okay. Great. And I was going to ask. It does note a one-time expense, and I remember that Bridgeway.
I think that explains that.
And once again, I commend your organization for stepping in and providing that assistance to Bridgeway. It's truly a needed activity. So I guess where I'm going is just understanding the fact that your budget was not fundamentally then reduced as a result of the reduction in revenue realized through the fund.
You're correct, Mr. Chairman, Councilman Greenspan.
Okay, and since we met yesterday, I heard a lot of your presentation, so you answered my questions yesterday. I just have one other question. My colleagues can stand it. Was last year when the budget was presented, we found out afterwards that there were salary increases offered that were not presented at the time that you explained your budget. In your budget, are there projected salary increases either with the current budget if you receive no increase, or if any portion of the $16 million is added? Do you anticipate in the next 2 years salary increases?
This budget does not have any salary increases because it's not part of the administrative budget. The administrative dollars as directed by this council only comes from state and federal funding.
Very good, thank you. That's right, because last year our appropriation was only for programming, no
Yeah,
administrative.
Mr. Chairman, you are correct. These dollars are only for services to citizens, period, for this proposal.
Okay, great, thank you. I have no other questions.
Okay, we welcome Councilman Rogers to the committee, and Ms. Simon is next.
Thank you. Just want to make a statement as well that what I see is overlapping of services throughout a lot of the proposed extension of services. The heroin crisis is evident, but it's being addressed by different agencies and different departments, and the Board of Health has an opiate task force that it's working on. I want to see who you're proposed to work with in collaboration for all of your proposed new services. And I know you can't do that today, I'm not going to ask, but I want to see the connections and the collaboration that's envisioned for all of these programs. And so we as a council can see where we can save and try to just get a handle on the overlap that's evident here. And in terms of, I pinpointed one program to go to hospitals, to work with physicians, and I don't see how that is something that we as a county are in a position or should be looking to do, to go into the medical facilities and start training doctors about addiction. That would be a place where there should be some collaboration and different sources of funding, so I just want, what I'm looking for is your goal, how you're going to collaborate. Okay. And that's an example right there is, do we as a county want to start training doctors?
Okay, Councilwoman Simon, to the chair, and we'll provide that for you on a program-by-program basis. Thank you.
Okay, Councilman Rogers is indicating no questions. We're into the second round. I have two requests. It's Ms. Conwell followed by Germana. Please proceed.
Through the chair to the director, and you'll probably have to send us this information. The Adams Board saves hospitals how much money and how you determine that. The other question, how do you determine the number of new consumers scheduled for your assessments, your scale assessments? How is that determined?
I could answer part of the first question.
Well, the first one was a question you could probably send us
we'll
the
get that for
information.
you.
Yeah.
The second question, I didn't totally understand.
How do you determine the number of new consumers scheduled for the scale assessment?
Well, they're either, we classified them on a basis of severity of disability. And they're 1, 2, 3, 4, and 5. And those that are classified 3, 4, and 5, which is moderate to severe, we classify in this scale assessment. We are hopefully going down to 2, which is a pre-moderate, which will open up the system to more individuals that have depression or going on severe depression. So we're finding that the SCALE program hopefully can handle that. SCALE is our single assessment and intake program in terms of mental illness. And we hope at a point in time that we could tell you by numbers and hopefully by cost, the number of individuals that have what level of mental illness disability, how many they are, and by how long it takes to get an initial assessment, an initial evaluation, and initial treatment. And that is our ultimate goal. And we've been working on it so that we're getting very, very close to getting those numbers and having the providers provide that to us. We're not there yet, but that is the long-range goal. So the assessment level is determined by the degree of disability that is determined at intake, and we go from there.
Will that also determine how long they need treatment for?
The length of treatment can vary, but generally overall, we would by history have historical data as to how long various treatments are.
And how long do you think it would be before you finalize getting the scale? What number of years
I hope
do you
that we could complete that within the next 18 to 24 months.
And I believe you touched on this. There's gaps in the system as I was going through my own mental health, traveling of various agencies. Even though there's a plethora of programs and funding sources, why do some individuals seem to fall through the cracks in the system? And what are the gaps? And you can provide this later, but I think you touched on it. What plans do you have in closing these gaps? So the items that you presented to us today, is that kind of your way at looking at what is needed in the services and your plans sort of in closing the gaps in the system?
Mr. Chairman, to Councilman Conwell, basically our system is grossly underfunded. And when you have an underfunded, under-resourced system, you have to, as some of you requested, prioritize things. And the prioritization, unfortunately, leads to not everybody being served. And that is a hard thing to say and or accept. But the reality is, according to the study we had done a couple years ago, and the reality we have by going and sitting with people in the community, too many people in our community are not being served, and that's where one would say they fall through the cracks. And hopefully that all these cracks we are talking about are dealt with through the treatment programs and the prevention programs that we have put in front of you.
Thank you.
Councilman Germain, then Gallagher.
Thank you, Mr. Chairman. Just flipping through this information you gave me, thought occurred to me about transportation. And I'm just wondering, has RTA ever considered having a lower fee for people for doctor's appointments or counseling treatments?
I don't know if I caught that last part in terms of transportation, a lower fee for the
Correct.
treatment?
Correct.
Well, we can't, I don't think we could determine what a psychiatrist or somebody would charge in terms of lowering a fee. There are certain guidelines that we use that are set by the state.
What I was referring to is just the transportation part, or the RTA.
Oh, I see, okay. Thank you for, I was going the wrong way, I apologize. Actually, we have talked about that and figuring out how to get the same break that students at CSU get, which is extraordinary. So that is a continuing discussion point that we have. I think for $5, they could get a pass for a month at RTA. So when we go out to talk to our consumers and when they come to talk to us, that is one of their top priorities. They say, look, besides everything else, we need to figure out how we could get from one place to another place, and that's the transportation cost. And it gets into dialogues and discussions about what could we do representing them with major transportation systems.
So the answer is no. There is no consideration for lower.
At this point in time, there isn't any.
Okay.
Councilman Gallagher.
I've submitted legislation, and this isn't just specifically for you, but we'll be discussing it next week, whereby if it passes, that the council will have an ordinance where once your budget's set, and if there aren't raises requested within it, you're not going to be able to take savings or any other funds and move it on to raises for employees. You're going to have to come back to us and request that. So it's budgetary mechanics that we didn't have before that we've had problems, not just with you, with other organizations within the county. So hopefully, and my colleagues, that's been moved on to all of you. If you'll review that, I think it's a standard that we need to present to everybody in the county. And we're trying to keep everybody on. You don't work harder than anybody in any other division. Everybody's part of the family here. We're in one mode. So hopefully that's coming. And if you are looking at raises, I would suggest that you alter.
I will look at it. Thank you.
Your request. And just a comment, and I know I had a family in my district, and you went above and beyond, as far as I'm concerned, to try and get this individual help and the family help. And it's just so difficult and heart-wrenching when you have those situations where time has run out on the individual and there's just nothing you can do. So believe me, going back to President Connolly's statement that while some of us may seem as though we're not caring and loving towards your concerns, they are our concerns. And these are people in need and people in help, and having had that last year and having to deal with it personally, I mean, it really is a difficult situation and hard to, in some instances, let people go. So, but dollars are dollars, and there's only so much we can do. And what Councilman Simon said, if there's any way in which we can coordinate with other organizations within or any outside of the county, I think we really need to start looking at that. Thank you.
Thank you.
And I appreciate everything you people did for that family. It was wonderful.
Anything else? Okay. Thank you very much.
Thank you, Mr. Chairman, members of the committee.
Okay, before we move on to developmental disabilities, we had an item on our agenda. I have not received any requests, but I just want to make sure we had an item for any last departmental appeals for changes not related to Health and Human Services. Are there any such requests? Okay, hearing that, I would bring to the committee's attention that the next two departments for the Board of Developmental Disabilities and the Board of Health, we really have no control over their budgets. And so they're on our schedule so that we get a good overview of everything under the county services. But I want people to be aware that they are independent and we don't get to control their budgets.
Mr. Chair.
Yes.
Just one. The clerk is passing out a summary, I believe you might have prepared it, of the Health and Human Service reductions prepared for the budget that was submitted. So just as a reference document. Did you prepare that? Or did Trevor prepare that?
I had prepared an earlier draft, but this is this, I believe, is an administration document.
Okay.
Is Trevor here?
It says executive.
Executive recommendation, okay. I just felt it was appropriate as we're reviewing this, and I apologize for not discussing it with the chair first, just to understand what the recommended cuts or reductions were in order to balance the budget. I apologize for not discussing it with you earlier.
Okay. This document was provided by OBM, so we appreciate this this information. I think it's a little bit more detailed than I had originally drafted, so that's useful. Okay, so next we have County Board of Developmental Disabilities. Ms. Kelly Petty, please come forward.
Good morning, Mr. Miller and members of the council. The Board of Developmental Disabilities provides a variety of services and supports to more than 10,000 people annually of all ages. Our full range of services and supports cover the lifespan and provide needed supports from birth to death. Last month, County Boards of Developmental Disabilities in Ohio celebrated our 46th anniversary, having been established by the Ohio General Assembly in October of 1967. I'd like to extend an invitation to each of you to visit any of our program sites at any time that is convenient to you. Our 2014 Program and Expenditures Plan sets a spending level of $202.5 million. And our estimated expenditures for 2015 is $197 million. Our budget plan was published for comment on September 26th and approved by our board following a public hearing on October 24th. Expenditures exceed revenue. This was anticipated and will be explained further in our presentation. All 2013 accomplishments and 2014 goals are listed in the unabridged copy of the Program and Expenditures Plan, which you all have been provided a copy of. I'd like to share some of the trends and service pressures that we experience and that contribute to our 2014 plan. Like all local governments, we've experienced a significant decrease in revenue over the last several years. We've lost tangible personal property tax revenue, we've lost revenue due to a decline in real property value, and we've lost revenue we've historically received from the Ohio Department of Developmental Disabilities through the state budget process. We've been operating with a 3.9 mil continuing levy since 2005, which provides the largest portion of our funding. The Board of DD receives no general revenue dollars. Like all levy cycles, we anticipated that our continuing levy would generate more revenue in its early years and decline over time. For that reason, we began planning ahead and working to build a reserve. We aggressively pursued and maximized other revenue sources and took a disciplined approach to spending. We were also able to take advantage of a lawsuit settlement and federal stimulus dollars. We are committed to extending out our levy as long as possible by using the reserves we've worked so hard to establish over the last 8 years. Another trend that we're experiencing is a reduction in personnel. We're trying to operate as efficiently as possible and have been able to reduce 144 positions over the last 5 years, or about 12% of our staff. We have expanded the use of Medicaid waivers, which allows us to stretch our levy dollars and serve more people. However, there is an impact of what we know as waiver match, or our local waiver match commitment. For people enrolled on a Medicaid waiver, the Board of Developmental Disabilities has to pay approximately 40% of their service cost. This is known as our local Medicaid or waiver match commitment and comes from our local levy dollars. As more people enroll on waivers, our local match commitment grows, and we are also subject to fluctuations in the waiver match rate. So from time to time, it goes up from 40% or it may decrease. The increase in our waiver match commitment is the single greatest contributing factor to the increase in our planned expenditures for 2014. The expanded use of Medicaid waivers has also led to a growing market of options for consumer choice. Providers such as United Cerebral Palsy, Vocational Guidance Services, Koinonia, Jewish Family Services, and Welcome House, among others, are now available choices to individuals of DD, for individuals with DD for day services. In addition to allowing us to avoid waiting lists for day services, this has had a positive economic impact of our levy and federal Medicaid dollars to the greater community, as each of these agencies mentioned employ hundreds of people. We do, however, continue to see a high waiting list for residential services, which tend to be our most expensive service. This is the only area in which we have a waiting list. Related to this, we are seeing a change in the needs and the types of people presenting themselves in need of residential placement. People currently in need of residential placement tend to be young, in their early 20s or late teens, with complex, challenging needs. They are often involved in multiple systems. We are cognizant that if we enroll one of these individuals on an individual options waiver to fund their residential support, we are making a lifetime commitment of that Medicaid match. The last trend that I want to mention is an expansion of employment opportunities for people with developmental disabilities. There's a growing trend around the country and within the state to move people away from sheltered or segregated work environments and to support them in community jobs, preferably typical minimum wage or better jobs. This trend will undoubtedly have an impact on the way in which we provide services going into the future. You may be familiar with some of our own entrepreneurial ventures that have been developed to create jobs for people with developmental disabilities. In 2013, we expanded our urban farming program and opened a third Just a Buck retail store. We also expanded our food service program by opening a cafe in the Westlake Library, and all of these programs employ people with developmental disabilities. Again, I'd like to invite you to visit these or any of our program sites at your convenience. And at this time, I'd like to turn the mic over to our Chief Financial Officer, David Vasaki, to review the budget numbers with you.
Just go through this very quickly. It is a budget hearing, so I guess there has to be a piece of our presentation that is driven to the numbers and things like that. So what we really are doing is trying to give you a highlight to where the changes are occurring as quickly as possible. And I'll try to respond to some of the questions you asked Director Danahan, because I think, again, we are very similar in many of the different things. On revenues, we are reaching and have reached a low point back to 2005 is when we had these kind of revenue dollars coming in. And after probably 20 years or 25 years of growth on the revenue side, we are seeing a reduction. And we are down $13 million in what we're calling the continuing levy era of the board. And that is a sizable amount of money. It represents about 6.5% of our revenue dollars in a short period of time. State dollars are a very small part of our budget. And again, if you looked at it historically, one of the questions that was asked is we have really become a two-pronged system. Local dollars, which are now will be about $104 million, and on the other side is the federal dollars. And those are drawn down by waivers, and we have a very good system of waiver support. When you look at our numbers, also keep in mind that about $75 million comes to this board by drawing down those resources. They don't go through our budgets, our income statements, but they are provided to private providers and agencies that provide services to folks with developmental disabilities. The pie chart just shows you how strong that has become, where 90% of the dollars that come to the board are either levy related or federal related. Someone asked earlier about other, and 5% of the dollars we have are called other or miscellaneous. And what that makes, most of what that is again, a part of it is donation, and a part of it is in terms of literally annual evaluations and reviews by agencies that look at our dollar values and reconcile them to, and in the past, we've been able to bring in some additional revenues through that process. We also have given you, and again, I won't go through it in detail, this document is very comprehensive in terms of all the other kind of pieces, parts you may have in terms of that. So at the back, you can see where the others revenues are and those kind of pieces of it. Expenses, very lean budget. It is increased, but when you realize that 6.65% of the increase is in the waiver match, what you see is that there literally is a decrease in the total budget of about $2 million, just under that. We have been directed to add the VRP3 grant. It's a grant with Rehab Services Commission, another state entity, and our role as fiscal agent is changing to being completely responsible for that. So waiver match and VRP3 are the only two things that are being brought into this budget as something a little different than we've had before. The rest of the budget, as I said, flat, but it is reduced. Somebody asked a question about salaries. We have a 2% raise in this. It was a negotiated raise with our unions. We as a board feel that our union, our labor staff, as well as our non-bargaining staff work together on everything that is of services to people with disabilities. So we have extended that 2%.
On that 2%, is that per year or one time?
It's per year.
Per year, okay.
Yeah. And just to offset that, the net increase in wages is 0.1%. So we've reduced costs in other areas to be able to pay for that. An aside, about 3/4 of that will be, maybe even 1/4 of it will go to an increase in the premiums paid for healthcare, and there is some inflation, obviously, that our community is experiencing. So 0.1% net increase, but 2% in terms of salaries, and we always want to be upfront with all that. You can just see a little bit here about the Kelly shared the $2 million budget. It's up about $5.5 million from the year before, or 2.8%, but the majority of that is in that waiver match line item. And we also identify here for you in terms of the slide that we will draw down some of those strategic reserves we have this year. A question has been asked to us, why would you do that? And when you have a sharp decline in revenues, we believe that it was important not to change the service experience for the people that we serve. And so we went to our savings account, we went to our budget, and what we call our strategic reserve, and we'll begin to use some of those dollars that are there for that reason and to continue programs and services going forward. Here's a budget variance. CFOs like to show change, and because it does tell you something about, and there's a couple slides here I think that'll be helpful to you. In terms of, first of all, 92% of what we do and spend money on is staff, benefits, or resources like contracts and things like that. The other 8% of our budget is things, utilities, building improvements, and things like that. So we're very much a people business, and you can see here very quickly in this slide here of budget variances that there's very little change, 0.1% in the budget under wages and benefits. And our benefit area is really very flat. In fact, actually a 0.5% reduction. You can see the large amount of local match growth, and that makes up right now about 21 cents out of every dollar we spend goes to federal match. And again, $75 million comes back to this community as additional resources because we're able to use those local dollars in that way. We draw down, and it really becomes an economic multiplier for the organization. The bottom line is at the very bottom. Without waiver match, again, you see a budget that is just a little bit under 0.1% reduction. This again gives you a picture of how those, in the pie, the expenditures are broken out by department. And I'll have a little better picture here on the next slide where we look at budget allocation by program. This one's kind of interesting because I think in your position you want to know trends. You want to see where things are changing. Here's 10 years worth of budget information and broken out by the programs this board has. And if you look at that waiver match as your first category, you can see we've gone from $13 million to $41 million. A tremendous amount of dollars are going into drawing down those federal dollars, and all of that combined is programs and services for folks with developmental disability. CMS is our community Medicaid services. That's our area of what would be called case management in the old days. We call it service and support administration. It also includes residential services. And probably half of that budget is on the residential side, maybe even a little bit more than that in terms of where the budget dollars are spent. In terms of services to adults, the high point was in 2011, and we're beginning to get a little bit smaller in that area as more and more people choose private providers, and private providers bill under the waiver. It doesn't go through our books, but the services are there. Employment is a huge part of the future. Today, the belief is that everyone with a developmental disability has a right to a job and has a right to all the things around to get them to that job and successful. And so you see that's an area of the program that's growing. And again, over the last 10 years, it's grown by about 50%, but there's a huge initiative statewide to make that a bigger part of our services. Services to children, kind of an interesting area here. You see a reverse. Again, those resources that were spent 10 years ago are being spent in other areas today. What's really happening is that we are doing more and more with local schools. That's where children should be served. And we are bringing the knowledge and expertise that we have in terms of staff to work with and work with children and bring that right to the individual in the school or the teacher in the school. And because of that, we've maximized, it's kind of a train the trainer kind of a model, and we really have done a tremendous amount and then taken those extra dollars and put them in other areas like waiver match and things like that. What's called special services includes PT, OT, speech and language therapies, nursing, psychology. That's been basically a balanced kind of a program. We're spending a little bit more today, but not dramatically. Transportation was a big part of our world. It's becoming a little bit smaller. People are using RTA. More people are being served closer to where they live. And because of that, we've been able to save some significant dollars and, again, move them to other areas in the budget. And last is other, and it's really a catch-all of our budget numbers. It includes administration, it includes operations, it includes IT, what's called the MUI department, and finance. And in the middle 2009, 10, and 11, we were able to access some federal dollars called AERA dollars, and we were able to make some major improvements on our buildings. So if you get your roofs done, you don't have to be spending those kind of dollars for the next 20 or 25 years after it. So you can see the high point was around 2010, and again, we have a reduction this year. So that's kind of a good quick picture of expenditures. And the last one is what we call the variance report of the 2 years of the budget. In our world, a budget must be approved each year. It's by code, so next year we'll go through a similar planning process. But because I think that it's a very healthy thing to have a 2-year budget, and the county has gone to it, we give you what we call our projections of budget for 2015. When you look at it real quickly, what you do get to see is we believe the revenue side is probably bottoming out or leveling off, however you want to say it. We do believe we can generate a few more millions of dollars, but that really is a difficult area, and as a business person, it's one of those little red flags that we all worry about when your revenues either decline or level off. On the other hand, you can see where we see the changes occurring in the next 24 months in terms of wages, benefits, waiver match, and that waiver match item will probably grow, unless we choose to stop that growth, by about $3 million each year. So you got to find some way to pay for that, and we're going to look to wages and benefits and contracts to accomplish that. The bottom line is we still will be spending more than we take in, but again, we'll use our reserve there. But we've brought that into a differential that is much more reasonable. So hopefully that gives you a good feel. If we have any questions, Kelly and I'm sure will try to answer them. And look at this document, because I think it really does have a ton of the questions you might have had earlier, information you might have had.
Okay, we're open for questions, and we have Councilman Rogers and Councilman Brady.
Well, thank you. I'm just wondering the Medicaid waiver match, the increase. Can you show an increase in the amount of people served directly correlated to that number, and what that number is?
Yes, there are demographic numbers in this entire program and expenditures plan, but yes, we have definitely seen a steady increase in the number of waiver recipients over the years. Currently, we have about 1,900 people enrolled on what's called the individual options waiver that typically pays for residential type support plus day support. We have, I think, about 1,700 individuals that are enrolled on what's known as the level 1 waiver. Typically that funds just day program plus a very little bit of in-home support like respite care for a family. And then there's a couple of other Medicaid waivers that we use that one is new, it's called the self waiver. It's really just getting started. And then another waiver that we inherited called the transitions DD waiver.
So, just by example, from 2005, you were spending $13 million, and now it's projected by 14 to be up 41 million. Is that about how many people would you say that represents?
Well, there is a chart in your in the large packet. I'm sorry, there's no page numbers, but it's called 7 years residential slash beds, and it shows the overall increases from December of 2007 to what we're projecting for the end of this year. And so you can very quickly see that there's just been a huge increase in the number of people enrolled in these programs.
Okay, thank you.
Councilman Brady.
Thank you, Mr. Chairman. Good afternoon. You folks do some of the most important work that goes on in this community. You're, highly revered and considered to be, a real model in terms of the very important work you do. That everyone, if they don't have a friend or an extended family member, have some sense of how important this work is. So, with that said, everybody else in this room and all the people that have come through here also strive in their own way to be part of the great things that this community does to make this the kind of community we can be proud to live in. But you are different in that you are somewhat insulated from public accountability. So I hope you will not take offense to the fact that we still feel that as the elected officials of this county, we have the need to understand what you do, as well as the departments that we are asked to fund. So I'd like to ask you, first of all, with all due respect, of course, when does your levy come up again? I know you're, only every 10 years or something amazing like that.
It's a continuing levy.
It's a continuing levy, so you don't come up at all. And that's even more convenient, particularly for all the competing levies. I'm sorry.
Just one other thought, though. With that, there's a huge responsibility with Medicaid, that piece of our budget. And when you think about $40 million in the state Ohio Revised Code, county boards are required to have protection of that money for 3 years. So when the decision was made way back when, 2006, to go to a continuing levy, one of the reasons is this growing responsibility in that Medicaid area and to fund it. And the elected officials at that time saw that as kind of a critical thing, that it would be very difficult if you were on a year cycle. So just a historical piece.
Okay, thank you. I know that there are government agencies that keep track of what's going on. I didn't mean to imply that there wasn't, if that's what you meant. How does one become a member of the board?
A member on our board?
Yes.
We have 5 individuals who are appointed by the county executive with your approval, and 2 members are appointed by the probate judge.
Okay, so
They
that
have
would be
up to 3 4-year terms.
So that would be an important point at which you interface with us in terms of our responsibilities. I just wanted to make that sure. It seems to be maybe we have less contact, and I don't blame you for that. We just have less contact because you don't come before us every month or so asking for us to approve a contract or for a contract change. So we just obviously have less contact with you. I know, what is it, Terry Ryan, and of course there was the what did you call him, executive director or CEO or a director for so many years that people were so familiar with, and he recently retired. And I don't know if this is the case, but what I've been told is that the position that he held, which I believe, ma'am, you hold now,
Yes.
was actually not even posted. And I'm asking why a position like this could possibly not be posted. Not by you, because it's the board that has hired you. So I'm not asking you to answer that question. But who would be responsible for the posting of that position or the not posting of that position? Or have some kind of, how could one come to the conclusion that a position like that, when some of the positions which much less authority are required intensely throughout county government to be posted. How is that the case?
This is Arabag Dazarian. He's our current board vice president. You may wish to respond.
It's my first appearance. I just want to say there was a very careful succession plan and discussion in many of our meetings with the board, and we, with Kelly's background, and we had discussed with our executive board in many, many sessions a very careful succession plan so that it was, we were all comfortable. I think Kelly was promoted at least a year or two, a year and a half as the assistant superintendent. She performed very well in those duties, and Dr. Ryan delegated a lot of his key responsibilities, so we had a very careful succession plan. She served extremely competently on the board and in all of her previous positions. So at least as a board member, I can say I believe that if you look at the process, we followed a very good process and carefully selected what we thought was the best available candidate with a proven track record. Thank you.
I appreciate that. I don't have any doubt that it's not only true, but that is, exactly as you're presenting it. I would be surprised in some ways if you hadn't carefully planned the succession of your director. But you must understand, at least from this council person, that you can't possibly see, regardless of that, yourselves as being above the standards that everyone else is held to.
I'm not in a position to respond to that other than I described the process that we went through. So.
Well, I mean, this is uncomfortable for me because I have very high regard for the work that you do. It's so important in this county, but everyone has to be held to the same standard, regardless of their abilities and regardless of their good intentions and regardless of their status. And I have to, in the course of this hearing, say that. So I'm finished.
Thank you for the opportunity to share that.
Ms. Conwell.
Yes, through the chair to the director. How many people with developmental disabilities you serve have dual diagnosis? Do you have a number?
I don't know off the top of my head. I can get that to you, though.
Okay, and so where I'm going with that is, are the individuals that have mental health issues supplemented anyway by the Adams Board or anything like that? So I'm just trying to understand how that.
We work very much on an individual by individual basis, and so it depends greatly on the circumstances. But I can tell you that we do work very closely and collaboratively with the Adams Board, and whenever we have many opportunities to discuss shared cases with them, and when there is someone whose need level is rising to an emergency state or something more, some more intervention needs to happen for that person, we sit down together and determine exactly where is the best place for this person to be and how should the funding work. We do look for opportunities to provide waivers. Since the Medicaid waiver is not available in their system, we will look for those kinds of opportunities if it makes sense to do that. And we have many shared living arrangements like that where we actually share the waiver match cost, and it's kind of a win-win situation for both agencies.
Let us know, provide us with how many times that may occur in a year or biennial between
That we share funding like that? Sure. A ballpark number is 5 to 10 times a year, but I'll get you the exact numbers for the last several years.
And you brought up the self-waiver program, and you stated, that was one of my questions, and you stated you participate in that. Is there any financial impact that the self-waiver program has?
Well, the self-waiver it just came into existence last summer, and the distinguishing feature of it is that it's what they call a self-directed waiver, so there's an expectation that the individual enrollee is actually involved in much more of the administrative type activities that the board otherwise might perform. But in exchange for that, the waiver is very flexible, and some of the rules that dictate the services that are provided are not as strict, and so people have more choices. The financial impact is that the waiver does have a cap, a cost cap. For children, it's $25,000, and for adults, it's $40,000, whereas with the individual options waiver, there is technically no individual cost cap. So it's an attractive waiver from our perspective, because if a person's needs can be met at that $40,000 level, it's something that we can rely on, as opposed to with the individual options waiver, it's sort of an open-ended amount. Does that answer your question?
Yes, it does. Thank you. Also, in our budget book, it explains that there was some increases in some contracts, but a decrease in the client services. Could you please explain how that can happen?
I'm sorry, could you repeat the question?
In our budget book, it describes that you had some increases in contracts, but also slight decrease in the client services.
Number of consumers. What we've tried to do over the last several years is, instead of contracting out for so many services, we allow people, through their freedom of choice of provider, by being enrolled on a Medicaid waiver, they can choose from among any waiver certified provider. And when they do that, that enables that provider just bills the waiver directly, and we're not actually involved in that transaction. As Dave said, those numbers don't go through our books, but we are providing the local Medicaid match for those situations. So the numbers may look like they've decreased, but the overall numbers of people being served somewhere by a waiver certified provider in the county has grown.
And so that also has a decrease in the client services, or what client services are being decreased?
Are you looking at just number of clients?
No, it just says a descriptive recommended update. It says an increase in the contracts, you explained that, and a slight decrease in client services. It doesn't tell us which client services are being decreased.
I think they're looking at something different.
Yeah, we're looking at our budget book from OBM that gives us, so I guess the question would be, are there any client services that you're planning on decreasing?
No, and as Dave mentioned, that's been very important to us, that they continue to experience the same level of services and support. And so we've done that through this, through allowing the provider to bill directly, and they have the freedom to choose from among those providers. So from a consumer's perspective, they're not really seeing anything different there, whether the provider had contracted with us or whether it's a direct waiver bill, the consumer experience is the same.
But it was incorrect on our end. And just one final question in regards to the presentation. Under the child services, he stated that you work with local schools. Is that CMSD, all the schools across board?
All Cuyahoga County school districts.
So there was a decrease, so I'm just wondering who picked up the amount of money? Was it the school system that is now putting in for those dollars, because it's a gradual decrease?
A couple things have happened over the past several years. One is we did transition away from our center-based school programs completely in 2012. So all of those students are now being served by their home school district. But the bigger impact just in the last year is that we changed our model of providing early intervention services, where we previously had a center-based program also for early intervention services. In 2012, we changed to an evidence-based model that the state Department of Health has been advocating for. And it's a home-based model where we coach the parents. People work on teams, and then they coach the parents and caregivers in the child's natural environment to work with the child to achieve their developmental milestones. And because of that change, we actually were able to reduce a number of staff, and that's why that budget number has gone down pretty significantly.
The ODE monies would go to the local school boards that were coming to us.
Per child.
Per child. So in the old days, if we delivered the service, they would come directly to us. In the current model, they go to the school board where the individual is.
Okay, and
A little bit decrease of revenue, but a significant decrease of expense.
And so all these children are in school because you stated that some of them are actually taught in the home setting?
The birth to 3, the early intervention is in-home. And the school-age children go to their home school districts. And we do provide what we call technical support teams to all 31 school districts around the county. And so those staff can go into the school, work with the teacher, work with the staff in the classroom to help them with behavior strategies, curriculum, PTOT, and then they can also provide that service in-home. If the family would like them to, they can carry that over into the home as well. But those services are more directed to the school personnel.
Thank you.
Anything else? Okay. Thank you very much. And we're going to go for a quick 5-minute break. We'll come back promptly at 10 minutes after, and then we'll be able to go to our lunch break.